This slide presentation will cover brain injury pathophysiology. Overall, brain injury can be traumatic in nature. It can be caused by inflammation and infection. Specifically, we're going to talk about abscesses, meningitis, and encephalitis. It can also be caused by brain tumors. The rest of the slides presentation will take each of these areas in turn. As far as traumatic brain injury, also known as TBI, every 21 seconds, someone in the U.S. suffers a TBI. It is the leading cause of death in ages 1 through 44. Males are 2 times more likely than females to suffer traumatic brain injury before the age of 24 years. TBI overall causes more death than stroke in ages 45 through 64. Approximately 280,000 people are supposed to be hospitalized this year just due to TBI, and 56,000 people will die from TBI this year. By definition, a traumatic brain injury is a traumatic insult to the brain. This insult may produce a diminished or altered state of consciousness, which can result in severe cognitive disabilities. It is also not degenerative or congenital in nature. It's distinguished from other issues by the suddenness of onset, the age at which it most likely occurs, many different kinds of brain damage patterns that may or may not result in a coma. And in addition to having these cognitive disabilities, there are also other injuries that can occur with a brain injury. So for example, in the past I've had patients who dove into a swimming pool in the shallow end, and they ended up hitting their head and causing a spinal cord injury. Well, the spinal cord injury was one problem. The other problem was the brain injury that went along with the spinal cord injury. Causes of traumatic brain injury, 47% are caused by falls. Motor vehicle accidents are also a leading cause. Any kind of assault. Sports injuries can result in all-out brain injuries or minor brain injuries known as concussions, which we'll cover in the spring semester. The outcome of a brain injury is going to forever change that person's life. Their personalities can be completely different. Their cognitive abilities could be completely different. Their ability to move and their social skills may also suffer. O'Sullivan defines traumatic brain injuries as being either local brain damage due to contusions, lacerations, hematomas, or herniations, brain herniations. It could be diffuse brain injury that is due to axonal shearing or small hemorrhages. The axonal shearing is caused by rapid acceleration, deceleration of the head backward and forward or side to side, which causes the axonal shearing. Or it can be secondary brain damage. Now, the secondary brain damage that happens is due to edema, hypoxia, hypotension, infection, electrolyte imbalances, concussion, or epilepsy. And the secondary brain damage can appear immediately or many years after the original injury. Next part of this PowerPoint, we'll talk about brain inflammation and infections. If you have a patient who is known to have an infectious disease in their central nervous system, the PT should protect yourself from the disease, understand how etiology and prognosis affects the patient's treatment goals. You need to understand all these processes to be able to communicate with other healthcare providers intelligently, as well as be able to provide patient and family education on the disease itself and the prognosis. Overall, CNS infection can be due to bacteria, parasites, fungi, or viruses, and know that all 4 organisms can attack the central nervous system, some through blood transmission and some through peripheral nervous system transmission. The first infectious process we'll talk about are brain abscesses. Brain abscesses happen when organisms reach brain tissue from somewhere else in the body. The organisms are typically a staphylococcus or a pseudomonas. And as I said, it's an inflammatory process that starts elsewhere, could be started in the lungs, heart, sinuses, or ear mastoiditis, and the organisms actually reach the brain tissue and cause an abscess. Typically it involves brain white matter, which would be specific tracts in the brain, and this infection causes an increase in intracranial pressure, ICP, which produces specific neurological symptoms of headaches, convulsions, hemiparesis, and incoordination. The next infectious process we'll talk about is leptomeningitis. The leptomeninges are collectively the pia and arachnoid matter. In leptomeningitis, infection is spread through the cerebral spinal fluid, or CSF, with an inflammatory process of the pia, arachnoid matter, and superficial CNS tissues. The organisms that enter the CSF either cross the blood-brain barrier or they enter the CSF through trauma. The cerebral spinal fluid itself is self-contained with no antibodies and few immune cells available, so it's ideal growth medium for various microorganisms. And leptomeningitis can be classified as either bacterial or viral. First, start looking at bacterial meningitis. It can be classified as either acute, subacute, or chronic, depending on how long the infection has been present. The agent that causes the meningitis is found to be age-specific, such that E. coli is the most common culprit in the neonate. H. influenzae is the most common infectious agent for childhood. N. meningitis in adolescents, and S. pneumonia for adults. With meningitis, the inflamed pia arachnoid matter causes increased intracranial pressure. It is categorized or diagnosed by having specific signs and symptoms as well as decreased blood sugar levels. The signs and symptoms are going to be headaches, vomiting, fever, alterations of consciousness, convulsions, nuchal rigidity, as well as irritability. If bacterial meningitis is untreated, it will lead to death. With bacterial meningitis, the patient will have a positive Brodzinski neck sign, which means that if the neck is flexed, it causes hip and knee flexion as well. With viral meningitis, the signs and symptoms are similar to the bacterial meningitis, but this condition is not life-threatening. It is classified as fulminating because it occurs suddenly in individuals and with great intensity. It more often affects children and young adults. And the viral contamination of the CSF, if you have an increase in lymphocytes in the CSF, this is known as acute viral lymphocytic meningitis. Viruses that cause viral meningitis include Coxsackie B, the mumps, echo, as well as lymphocytic choriomeningitis. And realize that with viral meningitis, in comparison to bacterial meningitis, the blood sugar levels are normal. Chronic meningitis is a much more slowly evolving infection. Agents that cause this chronic meningitis include Mycobacterium tuberculosis, which is also known to cause lung TB, and Treponema pallidum, which causes syphilis. In the case of chronic meningitis, a gelatinous exudate is present in the meninges, and there's an increase in immune system cells such as lymphocytes, plasma cells, macrophages, and fibroblasts. If the infection is in the subarachnoid space, it can lead to hydrocephalus. And signs and symptoms for chronic meningitis include headaches, vomiting, mental confusion, weight loss, fatigue, night sweats, chest pain, and general malaise. And medical management for meningitis depends on the type of meningitis that exists. If it's caused by bacteria, then it's treated with antibiotics. And if it's a viral meningitis, then you treat the patient's symptoms as best as you can, as well as administer antivirals if the infection is caught early enough. Another kind of infection that we need to be aware of is known as encephalitis. Encephalitis is a viral invasion of brain and spinal cord cells. This causes edema and inflammation in the brain and spinal cord and destroys white matter. The increase in edema and inflammation causes increased intracerebral pressure in the brain, which leads to transtentorial herniation. The viral latency period can last for months to years, so a person can have encephalitis that is slow to come on over a course of a long period of time. Signs and symptoms for encephalitis would be headaches, fever, nuchal rigidity, vomiting, general malaise, leading to coma, possible cranial nerve palsies, and hemiplegia. We should know that encephalitis is inflammation of the brain. Encephalomeningitis is inflammation of the brain and spinal cord. And encephalomyeloneuropathy is inflammation of the brain, spinal cord, as well as the peripheral nervous system. There are three major types of acute encephalitis that we need to be aware of. The first is the acute viral encephalitis. This virus affects mostly the frontal and temporal lobe gray matter. It is the most fatal type, and if the patient does survive, they will be left with severe dementia. This kind of virus is caused by herpes simplex, both type 1 and type 2, and the central nervous system is the area of the primary infection. Next, we have the parainfectious encephalitis, and this kind of encephalitis is associated with other infections in the body. For example, if a person has the measles caused by the rubella virus, they might end up with this kind of encephalitis. Alternatively, they could have the mumps caused by the paramyxovirus or the chickenpox, varicella zoster virus. Finally, we have the acute toxic encephalitis. This is more commonly known as Lyme disease and or West Nile virus. It's an example, both of these are an example of an arbovirus arthropod-borne systemic infection. Essentially, there's a vertebrate host, which would be a human, and the virus is transmitted through a mosquito bite or a tick bite. In contrast to the acute encephalitis, we also have slow virus encephalitis. This kind of encephalitis typically has long latent incubation periods. However, once the virus is fully entrenched in the central nervous system, it can be fatal within months. Typically characterized by progressive dementia, and it can often be caused by unconventional agents of infection known as prions. The Melanesian Kuru tribe are a group of cannibals who, when they eat the brains of other individuals infected with the prions, will acquire the slow virus encephalitis. It's characterized by bubbles and holes in the cortex of the brain that resemble a degenerative disease, and signs and symptoms of slow virus encephalitis include personality abnormalities, visual and spatial orientation abnormalities, as well as coordination problems, and eventually the disease will lead to severe dementia with myoclonus. The last kind of brain infection that we'll talk about is known as Creutzfeldt-Jacobs disease. There are three main ways of acquiring the disease. The first is through a familial or genetic mutation for the Creutzfeldt-Jakob disease protein. The second is sporadic. They have no idea how these people acquired the disease. It accounts for most of the people that have the disease, and they just develop the disease without any known cause. And the third way to acquire CJD is iatrogenic, mostly through exposure to brain tissue or other CNS tissues. CJD can take decades to show symptoms, and is often misdiagnosed. Approximately 13% of autopsy-diagnosed Alzheimer's patients were found to actually have Creutzfeldt-Jacobs disease. This disease should be considered when a patient develops rapid dementia as well as myoclonus. The initial symptoms can include depression, confusion, personality and behavioral changes, strange physical sensations, memory, coordination and visual problems, language, sight, muscle weakness, and coordination problems often worsen. Patients die within 6 months to 1 year. I had one patient since my time at Siskin that was diagnosed with Creutzfeldt-Jakob disease. It was a very difficult patient to diagnose. He had been suffering from symptoms for approximately 3 months before he came to Siskin. And we were told that he had some sort of brain injury or some sort of reoccurrence of a problem since his brain injury, which happened about 10 years ago. He presented with a really strange personality and behavior, and overall motorically was very, very ataxic. After being at Siskin for about a month, he was finally diagnosed with Creutzfeldt-Jacobs disease and died within a period of 3 months. And finally, on to the last cause, or the pathophysiology for brain injury, is brain tumors. The location and the size of the tumor are going to determine the clinical picture. Think of this as kind of like a stroke. If a stroke happens in a particular area of a brain, you know that you're going to see different signs and symptoms depending on what area of the brain that is responsible for controlling. Now, same thing happens with a tumor. If a tumor develops in one area of the brain, let's say it's an area of the brain, the frontal region, then you might expect personality changes or signs and symptoms of personality changes, whereas it affects the cerebellum, you might see ataxia, that sort of thing. Brain tumors, we should be aware that brain tumors can spread via the cerebral spinal fluid and produce a kind of meningitis known as carcinomatous meningitis. And as far as survival time, realize that the prognosis is poorer in older individuals. This slide just lists some common manifestations of brain tumors. Depending on, no matter where the tumor is located, you could always have an increase in intracranial pressure, and a triad of symptoms that represent increases in pressure would be headaches, nausea or vomiting, or papilledema, which is optic disc edema. As I said previously, if the tumor is around the area of the cerebellum, you would see disorders of gait, equilibrium, coordination, and ataxia.
If the tumor were somewhere in the area of the pituitary, or if the tumor were a pituitary tumor, as it grows, it starts to press on the optic chiasm. This would result in loss of the temporal visual field, which is the outside half of your visual field from both eyes.
You could have disorders of cognitive ability, speech and personality, dysfunctioning of any of the long motor tracts, sensory disturbances, and seizures, as well as upper motor neuron syndromes, which are characterized by a positive Babinski sign.
If someone is diagnosed with a primary CNS neoplasm, you should know that that means that the tumor originated within the nervous tissue itself. Examples of these kinds of tumors include the neuroglial tumors. Two main ones. The glioblastoma itself is definitely the most malignant of the tumors, and the astrocytoma is not as malignant, but it's the most common. Tumors that arise directly from the neuron are known as neuroblastomas. Tumors that arise directly from the pituitary are the pituitary adenomas. And a meningioma is a kind of tumor that arises from arachnoid cells.
In contrast, the brain tumor can be known as a secondary tumor if it originated in another spot in the body and metastasized to the brain or central nervous system. Typically, the secondary neoplasms originate from the lungs, breast, skin, kidney, and GI tract. Diagnosis for brain tumors requires the patient to present with clinical signs and symptoms. The physician will use radiology, CT, and MRIs. They might eventually do a tissue biopsy and then screen the biopsy to determine if it's benign or malignant. The clinical signs and symptoms for brain tumors in particular were listed on a previous slide. And if you're ever doing an outpatient screening and a patient presents with any of the specified neurological signs and symptoms, it's important to remember that you need to refer this patient for the possibility of a brain tumor. And we'll talk more about this in the vestibular portion of the class when we look at different vestibular disorders. And medical surgical management for a brain tumor is going to be chemotherapy, radiation, surgery, the stereotactic radiosurgery, and a combination of all of the above if necessary. Realize that a person with a brain tumor that is resected may not have had symptoms prior to the resection, or may have had mild symptoms such as a seizure prior to the resection, but after the resection, they might be a completely different person depending on which area of the brain came out with the tumor. So expect all kinds of problems. Any problem that you would anticipate seeing in a traumatic brain injured person could be evident in a person after surgery from a brain tumor.